Good morning, everybody, and welcome to the third of our town hall series. I'm Dr. Marc Boom, President and CEO of Houston Methodist, and it is my pleasure to welcome all of you. We have well over 500 close friends of Houston Methodist participating today. It's grown each of these town halls, and thank you for joining us. It means a lot to us that you are participating and that you are educating yourself about this virus and about what's happening in our community and what's happening at Houston Methodist. So again, thank you for all of the support that you all have provided throughout this now 3-month period and honestly 3-month marathon that we all feel like we are running. And as we'll talk about today, we're seeing a little uptick in Houston, so very timely that we are having this today. I'm delighted to have 3 colleagues here, and as in the previous talks, I will bat cleanup. I have Dr. Dirk Sossman here, who runs our academic institute. He's our chief academic officer and an executive vice president. He will actually come in second. First, we have Roberta Schwartz, who will start. Roberta Schwartz runs our main hospital. She's an executive vice president, has been with Houston Methodist for almost 20 years, not quite, came right around Tropical Storm Allison. She also serves as our chief innovation officer, and so she is going to take about how innovation has played a key role, particularly digital innovation, in our response. Dirk, as I mentioned, will speak after her. Dirk is going to talk about vaccines and some treatments and testing, really, especially. And then we have Dr. Kevin Grimes, who has headed our Remdesivir trial. Remdesivir, of course, you've heard many studies about that. We've been quite involved in that, and he's going to tell us about his work in that. And then I'll close things with a presentation really about the status at Houston Methodist, the status in the community. And throughout all of these, we'll try to answer literally the dozens and dozens and dozens of questions that you all have sent in, give you thorough answers as part of our talks, and then we will do some Q&A towards the end. So again, thank you for being here, and I'm going to turn things over to Roberta.
Thank you, Mark. It is absolutely a pleasure to be with all of you today. I'm going to give you a very quick talk about how the innovations that we already really had in place kind of served us well as we went through the first surge of COVID, and will continue to really serve us well for many, many years into the future. So we're pulling up the slides, and I'll ask to go to slide number 2. So, here we go. I control that. So as we really look at these, what's happened, I think there's such a beautiful, such a beauty that happened because we had really already started the Center for Innovation. And it's, as you really think about the Center for Innovation, which started little over a year ago, 18 months officially, and we had started activities a few months before that. We had put in so many innovations that really had begun prior to COVID. And so this was a slide used by Ken Lechterman, our CIO. Luck happens when preparation meets opportunity, and having been prepared and having really looked at the Center of Innovation before, starting digital innovations early, when COVID happened, we were able to quickly pivot and utilize all of those innovations. And really, let me tell you one of the extreme luck and timing issues that we had. We had just completed a project that wired 130 of our beds in the ICUs for virtual intensive care. We were scheduled to roll out our first unit in March. You can see the cameras that are behind the nurse up above. That is a camera by which an intensivist or in some cases here, a family could video into the rooms. We plan to turn these on over a slow period that would last about 6 months. We turned all of these cameras on within 2 weeks, staffed our virtual intensive care unit, and were able to actually utilize virtual intensive care. The beauty of that was that we had less people who had to go into the room. So you would see a room with 2 people going in, but 5 people standing outside of the rooms on various monitors that were able to look inside and guide the people in the room. We utilized less personal protective equipment in the early stages. And really, this was a way in the COVID rooms to be able to digitally bridge our families into the room. This is our command center. You can actually see this is where the virtual nurses and the virtual care doctors here, as well as doctors in from New York, were able to actually monitor our patients. So it was really amazing, picture worth 1,000 words to kind of see this command center at work so quickly. Not only did we train and turn on the virtual intensive care unit, but we also turned on every piece of virtual medicine within the hospital. We were utilizing virtual medicine before. You'll see it was at a fairly low rate, but it was growing, and it was growing steadily. But there was no success story like there was for virtual medicine, both virtual urgent care as well as in-home. And we used our tech hub. You're seeing Josh Soul in the background in a blue shirt. He actually was the key architect behind the technology hub. We turned that into a training site. We trained over 900 doctors, both in the tech hub and through virtual medicine, to actually do in-home if they were quarantined, if our patients were quarantined, as well as in hospital consults to do medicine within the rooms. We sent out over 1,400 iPads into our rooms so that people could use them. This is kind of one of two slides that I'll show you that shows the key growth of virtual visits. And the virtual visits are kind of that funky blue line, and you can see the extreme growth. We have two blues, a darker blue and a lighter blue. It's actually the lighter blue when you look at it. And you can see this huge growth of virtual visits as a percentage of total visits. So while everyone was quarantined at home, you could see that we were actually using virtual medicine about 70% of our visits. Now it's kind of down in that 30-40% range on June 8th, but it's amazing to see how much it got utilized while people were at home. And this is a slide that shows you the total number of visits, whether it was e-visits, virtual care visits, at home, in the hospital, over 140,000 visits that happened. And just so you see the extreme changes we had from before to afterwards, you can see how high the virtual urgent care volumes went in the wake of COVID. I'm often asked whether or not this trend will continue and whether or not this will have a permanent place. I would say to you absolutely yes. I think that our physicians discovered virtual care in a whole new way. Our patients discovered virtual care in a whole new way, and that's here to stay. But this wasn't the only area that we had innovations. We had turned on our care pathways, our digital care pathways. We turned on, now taking our lessons learned from surgery, we turned on 7 of these for our COVID patients, and the COVID patients actively use them. We also used robotic process automation. We turned on a number of robotic process automation bots. These are computer sequences. One of them was used to actually make sure we got our billing correct for the CARES Act. Pretty amazing to see this. We also used chat bots on the phone, and this was one of our chat bots by a company called Syllable, and we used this actually for a convalescent blood therapy trial. We were having thousands of phone calls come in, and the coordinators couldn't keep up with the phone calls, a lot of whom were not eligible to donate yet or weren't eligible to donate. So the bots were able actually to screen just those patients who were eligible for the trial, thus reducing the call volume coming into these coordinators. We use symptom checkers. These are kind of, I call them 20 questions of healthcare. This was the 20 questions of COVID. And these are symptom checkers that were able to guide people as opposed to waiting for somebody on the phone, waiting to get a hold of a doctor, even took the place of some virtual visits. So this was Buoy, a symptom checker that we used. As I said, we deployed 1,400 iPads. Those were used for everything from entertainment to getting in touch with families when we couldn't have visitors in the room, to video visits by our physicians. We used iPads actively to connect in multiple ways. And I think you'll find within another year, we'll have an iPad in every room for our patients to be able to do all of these functions. We also deployed 350 Alexas. These will eventually hook into our nurse call system, but at the beginning, we used them just so that people had another outlet for both entertainment, to get in touch, to use them to make phone calls to family and loved ones when they were in the hospital. So as I bring this to the close, there's no doubt that having the Center for Innovation, having all of the building blocks was really the key to being able to deploy everything very quickly. There were hundreds of people behind the scenes that made all of this happen. We also I don't want to leave without talking about some of the physical innovations that happen. These were some of our boxes that you probably heard about on the news. And these boxes were really there to protect our healthcare workers while they intubated, while they did COVID tests, as well as when they went into ICU rooms to change settings or hang IVs. So both the digital innovations and the physical innovations were really amazing and incredible during this time. So as I bring my talk to a close, I do want to remind everybody that we have hundreds of resources on our websites and lots of information both for employees and for the general audience for Houston Methodist about how to both take care of yourself as well as how to get resources about COVID. So really an amazing job that our web teams and our educational teams did to bring you more information in real time about COVID. So I get the opportunity now to turn you over to Dirk Sossman. He is going to take it from here and really spend the time talking about vaccines and testing and kind of catching you up on many of the questions you had in those areas. Dirk?
Thanks, Roberta, and thank you all for joining us this morning. You know, we at Houston Methodist just find it so rewarding to be able to talk to you and answer your questions and find out what's on your mind. So one of the things, or the things that we've gotten a lot of questions about recently, have been different kinds of testing and the progress that scientists are making towards developing a vaccine for COVID-19. Let's see. If you could move to the next slide. My clicker doesn't seem to be working too well. So there are two main kinds of tests that we employ nowadays for COVID-19. The first is called RT-PCR, or reverse transcriptase polymerase chain reaction. And that measures the actual genetic material of the virus in your cells and nasal passages. That is assuming that you get a good sample, you know, one of those nasopharyngeal swabs that everybody loves to hate. It is just about 100% accurate. There is very, very few false negatives or false positives. The second kind of test is antibodies against some of the antigens. So those yellow spiky proteins, or the protein inside the virus that holds the RNA in place. Those are measures of the body's reaction. There's a third kind of testing that isn't used very much now, but probably will become more important as time passes, and that's actually directly measuring those proteins that the body develops an antibody against. At the moment, there's really only one of those kinds of tests approved for use. Not clear how sensitive it is. But it's very rapid and can be used at the point of care. So what questions can you answer with these tests? The PCR tests for the viral RNA will tell you who is actually actively infected by the virus at the time the test was done. And the graph on the right-hand side of the slide, the horizontal axis shows the days since someone has become symptomatic, and the vertical axis shows you the rate of positive testing. So the black line is the PCR positivity, and as you can see, that is positive a few days before symptoms, when symptoms occur, and then gradually decreases. And as that decreases, the level of antibodies increases as the body reacts to the presence of the virus. So the nasal swab PCR testing is good for surveillance to see who is infected and asymptomatic. It's good for clinical diagnosis, for testing people who have symptoms that could be COVID-19, could be seasonal allergies, could be the flu, could be the common cold. This will tell you whether or not it's COVID-19. And then from a public health standpoint, it's also used for tracing contacts of people who've turned up to be infected. So this is quite a useful test. The antibody, as I said, tells you who has been infected. And it's pretty unclear at this time when we should be using that. It's certainly good for community surveillance. It will tell you what percentage of the population has been infected in some several week period of time. We use it very effectively for telling whether people who are volunteering for plasma donations in our convalescent plasma research have antibodies and are good donors. Whether or not it tells you who is immune to COVID-19 is obviously a subject of active research. It's a subject of huge importance, and this is what everybody wants to know. Because this could tell you whether it's safe to work in a particular place. It could give you peace of mind. You know, I've had the disease and I'm immune now. The problem is that we just don't know the answer to this. What I can tell you is that from our work with our plasma donors' plasma, we've tested whether different levels of antibodies will neutralize the virus in a test tube. And if you do have high levels of anti-COVID-19 antibodies, you will reliably neutralize the virus in a test tube. What we don't know is whether that translates to neutralizing the virus in your body. So I'd say a little cautious optimism there, but we really don't know the answer to that question. So the actual usefulness of antibody testing currently is not that high, except in relatively specialized situations. Now, we have tested our workforce with the PCR test for the active presence of the virus. And since we want to be the safest hospital in the world, that includes having a very safe workforce who is not going to give the virus to either each other or the patients. Back in April, when we really were facing very severe levels of this pandemic, we tested a bunch of our workers, about 3,000 people in total, and found that those who were working in the areas where they had the maximum exposure to COVID-19 patients, about 5% were testing positive, even though they were not symptomatic. In clinical workers, doctors, nurses, food service workers, phlebotomists, who were working in units that did not have COVID patients in them, it was about 1%. And then the administrative and non-clinical employees, basically we had nobody testing positive. And about 2% had antibodies as well. In June, after we enhanced our personal protective equipment deployment in the hospital, it's basically less than 1%, about 0.7% in all kinds of units, all different kinds of employees. So we're continuing the ongoing testing of employees to be sure that nothing creeps up on us. But this is also part of a huge surveillance, personal protective equipment, contact tracing, engineering controls, and environmental controls program to make the hospital safe. And I think we're pretty proud of the results. So let's turn to vaccines. And I just have to give you a 1-minute lesson of all you need to know about immunology, which Dr. Grimes is chuckling. He's wanting to see how I'm going to pull this off. but basically, the immune system exists in one of its many functions is to eliminate foreign invaders. So anything that is not recognized as yourself. The process is it recognizes something which we call an antigen, that is a foreign substance, and then it recruits both cells and antibodies to eliminate it. And that's shown in a schematic on the panel on the right-hand side. The body recognizes something as a foreign material, and it recruits a type of immune cell, which then develops in one of two pathways. The pathway shown in the star in red develops into a cell that produces antibodies that then attach to the virus and help the body to clear it. Alternatively, a cell can develop, shown with the green star, that actually kills infected cells. So if you think of a virus-infected cell as a virus factory, this kind of cytotoxic cell is kind of like a smart bomb that destroys that virus factory. What a vaccine does is put the immune system through its paces with that specific antigen to give it sort of a dress rehearsal so that it's got a head start when it encounters the real thing. Sounds simple, but in fact it's pretty complicated, and there are many places where vaccines can fail or where problems can develop in the course of developing vaccines. Is it safe? Because you're going to give this substance to hundreds of millions or billions of healthy people. So you got to be sure it's safe. Does it cause an immune response in both that antibody and cell-mediated immune system? Does that immune response actually neutralize the virus? Is it effective? Does it prevent infection? So that you are protected from any kind of infection? Or does it not totally protect you from infection, but makes the disease less severe? Kind of like a not very good flu vaccine. Does the immunity last for weeks, months, years, decades? And then the logistics. Can you produce billions of doses of this, get it around the world, and give it to people effectively? And will people take it? So there are a lot of problems, as you could tell from all those questions, and generally it takes 10 to 15 years to develop a new vaccine. The world record is held by the mumps vaccine, which was developed in only 4 years. And there are some diseases like HIV or malaria where we have still not been able to develop an effective vaccine. There are risks. They're pretty darn rare. Rarely a vaccine will make a disease worse. The classic example here is dengue fever. And some vaccines have side effects ranging from not very severe, like flu-like symptoms, sore arm. Sometimes they can be more severe, but again, it's very, very rare. And then pharma companies don't generally make money on vaccines, so they're not generally set up to make a lot of them. As the pandemic wanes, and this is what the English vaccine people are finding, it makes it harder to test the vaccine, because the way you test a vaccine, you give it to healthy people and you see if they get sick. And if nobody's getting sick, you can't really tell whether it's because of the vaccine or just because the virus went away. And we talked about the logistical challenges. The upside today is that we have many new technologies. There's incredible political pressure to get this done, and accordingly, billions and billions and billions of dollars are being invested in attacking this problem. I'm not going to go through these in great detail, but there are many technologies that people are working on. The classic technology that everybody knows is the one on the left, and that's viruses that are either weakened or killed and injected and just generate a regular immune response. You can also take bits and pieces of the viruses that are infectious and give them to safer viruses and introduce them into the body that way. And that's the panel on the right-hand side with the green label. But we can also, and this is where a lot of the excitement is, we can also use subunits of the virus, introduce them in totally artificial ways, and this speeds up the process of developing and deploying the vaccines tremendously. So you can just take the genes from the virus that code for the protein that you want to develop antibodies against, and just introduce those, and then your own cells are the factories for the vaccine. Or you can just give the purified proteins. So there are a lot of different ways to do this that are much, much faster than the ways we've done in the past. So where are we with this? As you probably read in the news, the government has picked five champions, but there are about 150 other contenders. Some of these are already in human trials. Many of them are hoping to get to efficacy trials really as early as this summer. And some of them believe they will have emergency use authorization from the FDA by the fall. I know one of the companies that I spoke to recently was pretty confident that they were going to have 20 or 30 million doses available this fall. The English company, AstraZeneca, that's working with Oxford University, is talking about having 100 million doses ready this fall. But I have to caution you, that is only if every single step of that process goes perfectly. So it could be significantly longer than that. And then, of course, the question, if you have a vaccine and you believe it works and you believe it's safe and you have all those doses ready and they're on the trucks and you have the nurses ready to give them to people, will people take it? Because as you know, vaccines are not entirely free of controversy in our society. And a recent survey showed that only about 50% of people who were surveyed were sure that they were going to take the vaccine if it was available. About another 20% weren't sure, and about 30% were absolutely not going to do it. And everybody in each one of those categories has their own reasons for giving those answers. But I can tell you, if only 50% of the population takes the vaccine, we're not going to develop herd immunity. And the pandemic will continue to run its course, albeit at a much lower and much presumably safer level. Because the folks like me who are age 60 and over are all quite eager to take this vaccine, and they are obviously the ones who are at the most serious risk for the disease. So I think that's a brief tour through testing, why we do it, what it's good for, and vaccines. I think the level of optimism about development of a vaccine continues to be cautiously relatively high. No game changers on the bad side have been found so far. It's now a real pleasure to turn the podium over to Dr. Kevin Grimes. He's Deputy Chair of Medicine. And all those times I was talking about the Remdesivir trial in one of these town halls, that was Dr. Grimes leading it. And you find out the quality of people when times get tough, and I think Dr. Grimes earned the respect and admiration of everybody in the hospital for the way he stood up and took charge. We really appreciate it. So it's great to have you here.
Well, it's great to be here. Thank you so much, Dirk. I'll tell you right now that you can sign me up for the vaccine if and when it becomes available. So thank you guys so much. It's really an honor to be here. It's really exciting. For those of you that do know me, know that I tend to tell things in allegories and stories. So I'm going to tell you my story here in a short period of time that happened. I was the principal investigator on the Remdesivir trial, and we were studying for both moderate and severe COVID-19. I happened to be at ground zero, if you will. Christopher Cortez called me early Saturday morning on March 14th and says, hey, look, Kevin, we're transferring in patients from our sister hospitals with proven COVID. They're on ventilators and they're in ARDS, which is a very severe progression of this disease into lung failure. I was talking and working with Dr. Cortez and also Dr. Perez from pharmacy about trying to develop and get a program for getting compassionate use drug to our patients for Remdesivir. At the time, my research, which albeit was, in the middle of a burgeoning pandemic, it seemed to be the best option at the time for trying to kill this virus. And as an infectious disease doctor, I feel that my job is to try to kill viruses or try to kill bugs to keep them from getting people sick, and trying to work as the team to support them throughout their hospitalization. When I found out that it was going to take up to 5 days to receive antivirals, not through any fault of anybody or the company, just that's the way the process takes, getting it through the FDA, getting it shipped to us, etc., I realized that was not going to be enough, and we needed to get drug into these patients the second that we had identified they had infection. So that following morning on March 16th, I was approached by Pauline Todd and the AOCT and asked if I wanted to be the principal investigator on that trial. And I had already sent some emails out that weekend saying, we really need to get a trial for this and we need to get drug into our patients ASAP. So that March 16th, we applied for the trial, and by March 23rd, we had the first patient in the trial. We enrolled for about 2 months and enrolled our last patient over the Memorial Day weekend when the trial ended. Just to remind you guys, I will have to admit I borrowed this slide. And Remdesivir acts as an antiviral agent. It's a nucleoside analog that interferes with viral replication. And you can see that it, just like Dr. Sossman was talking about, it interferes with that virus factory that the cells are making. And so my thought was, if we can stop the virus from reproducing, we can slow the progression into respiratory failure and needing ventilators. Just to remind you, the NIH trial did show in a placebo-controlled fashion that there was an improved time to recovery from 15 to 11 days, and that there was not a statistically significant, but a trend towards so, of a lower mortality rate in those that did receive Remdesivir. Our trials were twofold. There were two arms, or two specific protocols. One was for moderate disease and one was for severe disease. We were able to show in our trial, was able to show that Remdesivir, 5 days of Remdesivir was just as good as 10 days, and that will come important in a minute. Our trial was the simple trial. We did enroll 14 patients in the moderately ill arm of the trial. 14 of those were discharged. We were able to enroll 84 patients in the severe arm, and 78 of those were discharged. The moderately ill trial was a little harder to enroll in just because the patients weren't really that sick. They were going to be discharged in a day or two. They were people that didn't need to be on oxygen or an ICU, and most of patients we approached did decline the trial. We were also able to get 7 patients with compassionate use drug. One thing we were very happy about is we were able to get compassionate use drug for 2 pregnant women. Both mom and babies did well and went home from the hospital. The data on the NIH trial allowed the FDA to approve emergency use access for Remdesivir, and we were very blessed here that the trial was able to provide drug for about 2 months for our patients, and literally the week the trial ended, we were able to get emergency use access drug shipped to us for the Houston Methodist system. I would like to also note that we were able to develop a program to transfer in patients from our sister hospitals so they could be enrolled in the trial. So this was made available to patients throughout the Houston Methodist system. As of actually last night, when I checked with Dr. Perez, 134 patients system-wide have been treated with emergency use access Remdesivir. Actually, by this morning, it's 139. We thought this was important because by showing that 5 days was as good as 10, and there was a limited use or limited lot of the EUA drug, that we were able to treat twice as many patients. So rather than 70, we're up to 140 patients that have been treated with Remdesivir. I just want to thank really the people that were doing a lot of the work along with me, Dr. Catherine Perez and Dr. Chase Janik with pharmacy. Of course, our ICU nurses, our floor nurses, our respiratory therapists, these are the people that are taking care of our patients, and they're the ones who deserve all the kudos throughout all of this. I want to thank the Academic Office of Clinical Trials with Pauline Todd and Marc L, obviously our IRB, and countless numbers of researchers and support staff. And I just, things like this really take a village to take care of it. And this was my village here. This is the team that helped run this trial. They are still working very hard day in, day out, making sure the data is appropriate, that is cleaned well, and that we get all of our regulatory documents in. And we're very proud of the work that we've done here. And I'm very proud to have been able to help our patients in such a dire time.
Well, thank you, Dr. Grimes. Really appreciate that update, and it's been Remdesivir has been one of the lights in the in this journey that we are cautiously optimistic about, and certainly both from the trials and from the anecdotal evidence we've seen here. It is a meaningful, probably not game-changing drug, I think is fair to say, but one that's, I think, changing the situation for the better, along with convalescent plasma and other things like that. So, as you see from my three colleagues here that we've heard from, we have an amazing team here, and it's great for me because I've been able to really make sure that my bandwidth is being used at the political interface, at the community interface, when we have to go sometimes talk to a drug manufacturer or a supplier or things along those lines. And with a lot of the big questions, Dr. Sussman helps me a lot with those of, are we doing the right thing? What else do we need to do as a community? Where are things going? And all of those. We have a spectacular team, and they've really enabled that, and I'm deeply appreciative of all of them. So what I want to do today then is bring you up to date on where things are at Houston Methodist. I want to talk about some of those bigger questions. You all asked many of those bigger questions of me and us, so we'll cover a lot of the questions that came through during this time. And then, of course, we will have time for questions and answers at the end. So this is the curve that I follow every single day. I see lots of other data, of course, but this curve really shows the patients in-house across Houston Methodist. In the light blue line, you see the total number of patients at any given time. In the gold line, the lighter, there's a darker orange, and then the yellow gold line, we see ICU patients. What you see there, and we've reviewed this before, is a very steep ascent that happened and that quickly changed around April 10th. To me, that and many other things, very compelling evidence that the things that happened, the stay-at-home orders, all the changes of behavior, everything we put in place across our community worked. And there's lots of data nationally to, in my mind, unequivocally support the fact that needed to happen. Just look at that curve. If you drew that line up, we were going to be in real difficulty, and you'd see a similar curve at other hospitals. We actually peaked earlier than some of the other hospitals and went up faster than many of the hospital systems, but nonetheless would have been very concerning. And what we've seen since then, and really, down into the end of April, was a more gradual decline than the ascent. That's pretty typical. And then really a leveling off through most of the month of May. But as you can see, starting in the latter part of May and then accelerating into June, we're now seeing a pretty significant uptick. In fact, we're up between 40 and 50% from our lowest point. We're obviously not back at peak yet, but when I look at Texas Medical Center numbers, which we'll share, a lot closer to peak as a whole Texas Medical Center. One of the other things to look at with this then is that ICU line, because ultimately that indicates who's really sick and indicates really where some of the pinch points are in care. And so as you see, most of the uptick more recently is on the medical surgical side. That's the dark orange, and we're not seeing it as much, I'm knocking wood, in the gold line or the ICU line. We don't exactly know why that is. ICU utilization is a little bit of a lagging indicator. So is this simply that patients, we haven't seen them getting sick? Is there an age shift, which we do think we've seen a little younger aged, particularly as some of this is likely the result of opening back up the economy and the people going out more are younger? Are there things that we're doing treatment-wise? We do feel that way with Remdesivir, with proning, with avoiding ventilation, with many things that we've put into place, and convalescent plasma as well. So it's probably a little bit of all of the above. But I want to note how really a few days after Memorial Day, we saw this uptick. So my personal belief is that while we've been easing restrictions, we inevitably saw some increase. It's really about personal behaviors and people letting their guard down and starting to act as if this had never happened. And we have to change those behaviors, or we're going to be in a more challenging situation. And I'll review some more data with you coming up around that. If you look at our overall data across Houston Methodist, you can see a very large number of people who we've diagnosed positive. We've admitted over 1,100 people to the hospital. I showed you the number, at 141 on the last slide. These are snapshots in time, so 150 at the snapshot we took. This slide was 147 when I checked right before walking in here. And if you look at the discharges and deaths, we're going to be at 1,000 discharges before very long. And you can see 96 people who have passed away. That's a little less than a 10% mortality rate now, which is declining. And so another indicator, I think, that a lot of different dynamics may be going on. That's less than half of the mortality rate we saw in the city of New York when they were in the midst of the crisis. And so it matters that we're able to do this in a controlled fashion across our community and across our institution. This then gives you a little idea of where we are in the state of Texas. So the last time I pulled this slide together for a talk about a week ago, we were the 8th state in terms of numbers of cases. And of course, we're so large, we should be 2nd or 3rd, typically based on population. And we were 8th. We're now 7th. But interestingly, we have by far the lowest mortality. This is a case fatality rate, people we know have the disease and then how many die. And of course, this is in a setting of a state where we've tested actually on the lower end of the numbers of people per population indicators. And so we've done pretty well as a state. I don't think any of us can explain all of that, but most certainly some of that is getting out in front and keeping things in control, no doubt. If you look to the right, actually in Harris County, we're doing even better, and you would see the same with the surrounding counties, but it's just a little easier to display this way, and doing a little better than in Dallas County as well. So some reason for cautious optimism, but also that's how we want to keep it. We don't want to let that get out of our control and have that change. And so I look back at that curve, I look back at things that have happened in our city in Greater Houston, and I think we did a pretty darn good job, and I think we're seeing the good results of that. But kind of embedded in that, when people see that, they ask, well, so this is just the flu, right? It's maybe a little worse than the flu, and did we overreact? All those kinds of questions. And this is a fascinating slide. It is an emphatic answer to that question, and it's emphatic no. If you look at this is the number of weekly deaths across the United States from different illnesses. Now, everybody knows heart disease is the #1 killer normally. Cancer is the #1 killer. So you see the average weekly rate across a year there for the #1 and #2 killers in the United States. In the gold, you see one of the flu epidemics a couple of years ago, and you see similar with the gray. And you can see those do significantly increase the mortality during their peak months. There's no question. But they also tend to go up more gradually. And look at the red line, which is COVID-19. That shot out of the cannon like a bullet. Remember, that happened and the context then of shutting down most of the country. So just imagine where that line would have gone had it kept going up. And it most definitively hit #1 killer in the United States. And I'll show you those data here. But the #1 cause of death in the month of April across the United States was the coronavirus. If you lived in New York City, they had about 7x the number of deaths they would have expected during that period. That was all COVID. And so we are blessed that we did not experience that, but it is not simple luck. It is not simple geography. There are many of those factors involved. A lot of that is the actions that were taken and the actions of our community. So that's why it's so critically important that as we move forward, we don't let our guard down and we continue to focus. So another question a lot of people ask, and we talked about vaccines from Dirk, and Dirk talked about vaccines as one way of developing herd immunity. And of course, as he mentioned, we got to get everybody, or at least a critical mass of people, to agree to take those even, let alone all the other challenges. And probably the low end of herd immunity is around 60%. You can debate that a little bit. We don't know exactly, but that's a rough estimate. So I did some numbers here because people ask me, well, should we just let this go out? Keep the older at-risk people in their homes and let the younger people go out, let them all get sick, somehow isolate and insulate those older people, which is frankly not fully possible. And can we get there? So let's take New York, which is, of course, had the worst experience so far, but therefore is probably the closest to being able to develop herd immunity. at the absolute highest end, there's one study that suggests 19.9% of people in the middle of New York have antibodies. And that probably is an overestimate because there's some false positives and things in there, but we'll use that conservatively. Conservatively, only 60% of people need to be infected to get immunity. We know there's already been about 250 plus per 100,000 death rate in New York, which means it is very definitively the #1 cause of death in New York. Heart disease kills about 200 per 100,000 across a 12-month period, and here we are, let's call it a 3-month period in New York, where it's already well past heart disease. We know that people died in New York in hospitals probably at double the rate where it was more controlled and where they wasn't out of control. So if we assume that we basically need to run through 2 more sets of people getting sick because they're at 20% and we need to go to 60%, but they can do it with half the death rate that they did before because we've learned a lot and because it'll be in more control. And we assume some of those people might have died anyway. Roughly, bare bones minimum, you're talking 450 deaths per 100,000 people, which would make this, which would take call it an 850 or so death rate nationally per 100,000 people, would more than increase by 50% the deaths in the city of New York. I don't think that's possible, by any measure. You do rough math on places that may have a 3 or 4 or 5% prevalence. It's probably not quite that bad, but you're still talking, when I do the math, probably needing 200 deaths per 100,000 or something to get there. So realistically, I don't think, unless we have no choice, obviously, over the next couple of years, that choosing to go down a herd immunity path is really practical or reasonable. We know that. And in fact, then, what we need to be doing, and I tell people, we need to figure out we need to figure out how to flatten this curve that we flattened so far. We need to flatten the next curve, which is people who avoided hospitalizations and are having impact of that. We need to flatten the next curve, which is chronic disease, which may be impacted by some delays in care. And we need to flatten the curve in terms of the harm to the economy, the harm to the psychological health of individuals. The goal needs to be focusing on all of these, figuring out how to live together with the virus, keep it in some level of control so that we can do this. Unfortunately, in our very politically divided country, it's really tough to have the right discussions around that. Both political extremes have kind of camped out and staked out their positions, and a lot of discussions that should frankly be medically led and should be scientifically based have devolved into political discourse, unfortunately, many times. But this is the philosophy I take, is this is what we need to do. And why do I say that? Well, here's some evidence locally. This is Montgomery County. In Montgomery County, over the March-April period, they saw about a 40% or so increase in people dying at home. There's no good explanation for that other than they've been avoiding hospitals. Actually, our chief medical officer out there was correctly quoted as saying, and we're trying to really educate the public, we're really safe. You heard the numbers from Dirk as he talked about some of the surveillance that we've done. We know we can do this safely. Walk in our hospitals and you will see everybody masked. You will see everybody following our protocols. Times like this, we may be out of a mask, but those are few and far between. And if you walk in public areas, et cetera, very, very safe. We've had tens of thousands of patients cared for during this time. We've had thousands and thousands and thousands of employees coming to work, and they're not getting sick at any higher rate than what we see out in the community. And so we are safe. If you read a nice story on the bottom of the front page of the Houston Chronicle today about a couple that kind of got back together through this crisis. The young woman in the article had a neck mass that needed care. She was going to get it in Canada, ended up at Houston Methodist. She was quoted, we didn't prompt her with this, she was quoted as saying, I went into the hospital at Houston Methodist and it just felt like the safest place out there, and I couldn't agree more. So we need people to continue to seek care. There's study after study after study out there of harm, and so this is one out of Beth Israel Deaconess Medical Center in Boston, where we saw heart attacks and strokes both going down very significantly. There's no plausible biological reason for that kind of decrease. People are avoiding care and we're seeing harm. So a lot of you then ask, and certainly I ask, okay, where are we going from here? None of us who tell you the truth or can tell you we can know. We do know that in 7 out of 8 flu pandemics, again, let me be clear, this is not the flu, so we don't know if it will act like the flu, but it's somewhat close in terms of some of its behaviors. But we know there were initial peaks in the spring, and then it kind of went away mostly over the summer months and then came back with a vengeance in the fall. That's the kind of middle curve you see on the graph there, but we don't know if we're going to be in the top curve, which is really a terrible one, which is, big waves. The only way to get it down is to shut things down, come back down, et cetera. Or if we're going to be in the bottom curve where it's just some smaller peaks. And we just don't know when we look at this, but we are certainly concerned and planning for all those eventualities. Now, the government's been using, and this came out of the AEI really 2 months ago now, really a number of criteria to go forward. Sustained reduction in cases for 14 days. We've never really seen that in most of the states that have reopened. Can hospitals safely treat all patients? I can definitively say yes, emphatically. Are we able to test all people? We're doing pretty well these days. We actually, across the United States, have come up quite a bit. I'll show you that in a second. And are we able to monitor, to do the interviews, to do the case interviews, and then to do the contact tracing and the isolation? This is still a very weak point in almost every community across the country. The action plans across the country, this was one coming from Rockefeller Institute that talked about a 1-3-30 program. What that was saying is that mid-April when they put this out, that we could do 1 million tests in the United States a week, that within a month or so we needed to be at 3 million. Well, we do about 400,000 plus tests a day now, so just about at that across the United States, but that by fall really needed to be able to do 30 million tests a week. That's still a pretty significant challenge. I will say we can do about 1,600 tests a day now. Our peak day ever has been about 900, so we've not needed to pull that capacity into place, although we're going to do very significantly amped up surveillance of both patients and staff starting next week, and so we'll use more of that capacity. But assuming we can get everything in that's been committed to us by fall, if we see a potential fall surge, we'll be able to do somewhere between 10 and 13,000 PCR tests in a single day, which is a pretty phenomenal ramp up, and you're seeing that across the country. Contact tracing I alluded to, but most recommendations suggest that we need about 30 per 100,000. We're only at what we should be therefore at 2,000 in Houston. The city and county have each hired or mostly hired about 300 supplemental people in that. We're still behind the 8 ball. I will tell you, across the medical center, we're leaning in right now, trying to work with them to embed more of these people in the hospitals and really get that ball rolling more quickly. So one of our big responsibilities has been trying to help educate the public, keep the public aware of where we stand. This is the dashboard that y'all have hopefully seen. Go to the tmc.edu site, you'll see it. 5 things we measure right now, a couple of them in the yellow zone, which is of concern, and I'm going to share with you some of those data. So this is the trend in positive cases that have been diagnosed across the greater Houston area. In red, you see the 7-day moving average, and so that smooths out a lot of the weekend effect and other things. I've seen this morning slide. We put this in the deck today. It shot back up. That was a weekend effect that you're seeing dip back down. Not quite as high as last week, but it's still there. And there's no question as you look at that, we've seen an increase, and that inflection point around June 1st, about 5 days after Memorial Day, right about when you'd start to see people infecting each other from what I think were honestly lackadaisical and sort of letting our guard down kinds of behaviors, not by everybody, of course, but by too many people across our community. This is another way of looking at the same data, and this is by week. And so last week we had an average of 407 people diagnosed positive in our community, which is just about where we were at peak. Now, I know we're doing a lot more testing, but our percent positivity rates are up. These are all leading indicators. When we look at sort of more lagging indicators, we're also seeing hospitalizations come up. So these are the daily number of hospitalizations coming into Texas Medical Center hospitals. You see the red 7-day moving average. We were creeping down, kind of holding relatively steady state mostly through the month of May. On May 17th, with a 7-day moving average, you start to see it move up. We expect that, right? That's right about when you would have expected it based on the easing of restrictions. We have to figure out how to live with this virus. It's not reasonable to expect that it was going to continue going down unless we waited to open up much later, which we didn't. But you clearly see it starting to accelerate. And I can tell you all of us across the Texas Medical Center are concerned about that. And it's very clear at the state level, the intention is to keep going through these gates of reopenings. Personally, I think right now the data suggests we should just take a slow pause and maybe not go through the next gate quite yet. But I don't expect that's the decision that will be made. So we have to live with this virus. We have to be in that and of trying to have this, the virus with us and us keeping in control. So this depends on every single one of us. If we don't do the right things, if we let our guard down, if we breathe the sigh of relief because summer's here and Memorial Day's here, we're paying for this, big time. And so that's really one of my key messages today. We've been out there across all the news outlets and everything else trying to have that conversation. This is the ICU occupancy, which is ultimately the pinch point. And I showed you our data. Ours hasn't come up quite as fast as some of the other institutions. The bottom line is we're back up to ICU occupancy levels on aggregate that are close to where we were. Now, those were never out of control in our community. It's leveled off a little over the last few days, which I'm watching with some cautious optimism. But nonetheless, again, we have to watch this all very carefully. I do think when we give Remdesivir, when we use convalescent plasma, when we've learned how to prone people even before they get a breathing tube, proning means being on their stomach. It ventilates their lungs differently and a number of other things. When we've learned not to intubate until the last possible moment, all of those things I think are having a positive impact. But obviously we need to keep this in control and not have this spiral out of control. This slide has tons on it. That wasn't the intention to read it, but just to show that across the Texas Medical Center with the Greater Houston Partnership, with the city and county, much scenario planning is going on. I'm part of that call. There's 2 calls a week on Tuesdays and Fridays. One of the scenarios we did a couple weeks ago is, kind of the horror scenario that we hope we don't get a hurricane loaded on top of this. But obviously all the things we have to do as a community with a hurricane are very different in the era of COVID. We're going to actually repeat that tomorrow with a little more depth and bring both the mayor and the county judge into the discussion, which I think is really good. So I want you to know those kinds of things are happening. We've really pushed and taken the lead across the Texas Medical Center. So I want to get to wrap up so we can get to some questions. But with all of that as background, these are the things I've charged our institution with. We're Houston Methodist. We are going to do this better than anywhere else, anywhere. So first and foremost, as always, we will be the safest hospital system in the world, but never more necessary than now, that we will get volumes back. We have to get volumes back because we need to care for people who need us. And thankfully, we've seen that, and I'll show you some data. We're not there yet, but we're getting close. With that, we can't go forever with the, and a couple of you asked questions, with the dramatic financial impacts that all hospitals felt, particularly in the month of April. It was extraordinary and extreme. Thankfully, some governmental support to mitigate that. And the challenge to say, look, let's get back to break even. The fourth is, expecting a fall surge as a distinct possibility. We are going to stay operating. Now we may have a summer surge perhaps, and we are going to figure out how to stay operating. And then fifth, at all possibilities, last resort, we will avoid furloughs, layoffs, and pay cuts. We have not had a single furlough, layoff, pay cut at Houston Methodist. I'm very proud of that. I will tell you, in the middle of April, that took some real intestinal fortitude to make those decisions when we were seeing what was happening, but they were the right decisions because our people are ultimately the reason that we can do so very well. And now we're all getting back to work, and I feel cautiously optimistic that we're in really great shape around this, but we are obviously having to be very careful financially going forward. This is actually what's happened to the most extreme area, which is outpatient surgery, which not all of, but most of are more elective. And you can see those absolutely plummeted. They've come back very robustly. They've dwindled off a little slightly over the last couple of weeks, but that's really just because the inpatient side and many other complex things like transplant are coming back online. And so we are very much coming back online. But the big message for everybody is we all together need to continue the same best practices we've been talking about. I got a lot of questions about masking because boy, has there been no more political issue probably around this than masking. And it's a real shame because it didn't need to be political. Yes, there were disagreements in how to implement policies around that. But when it became political and a sign of politics as to whether one would wear it or not, that was just really, honestly, a tragedy. And I think it will cost lives and it will cost infections. This was an image from the Houston Chronicle. Look, let me be clear. Do we have a randomized controlled trial to say, let's take the city of Dallas and mask everybody and let's take the city of Houston and not, or vice versa? No, we don't. But we've known for decades that masks block outward transmission of viruses and bacteria. Why do you think we have every single person in an operating room wearing a mask, right? And we know that some studies, for example, this one in healthcare workers, you can drop transmission by at least 80%. In non-healthcare, where you may not use it quite as well, maybe you're not using the same types of masks. It's not a perfect study, but by at least 50%. Those are real, meaningful numbers. This is more of an opinion piece that then looked at a lot of studies and basically saying, look, at the end of the day, we don't have perfect data, but the benefits, no question, outweigh any possible harm from this. We need to do this. It's a social contract with each other. So most emphatically, yes, wear your masks. We have everybody everywhere in our institution wearing their masks unless they are in a unique situation like this or in their own personal space in an office. The last thing I'll put out here is because I got a lot of questions about airline travel. People would like to get out and about, of course. I am not an expert in this area. I will tell you there's an interesting article here, and it was in the Washington Post. You can Google this, but basically was an opinion piece from a professor at Harvard who has a title on kind of environmental safety. I didn't even know this field existed, but his point was basically that, look, the airlines have ventilation systems that are pretty much like the hospitals use in a room with a COVID patient. He actually said, turn up the vent, blow it on your face. It actually gives you a protective zone, and basically said, I don't think an airline flight in and of itself is that different than many other activities. So weigh it just like you would weigh the other activities you have of going out into the community. So with that, I want to thank you all very much. We're going to take a small break now to listen to some beautiful music from our Houston Methodist singers who we've listened to before. It's a very appropriate song for our times right now. And then we'll be back to answer some of the questions you've sent in and some of the questions you've been sending in now. Thank you.
You and I must make a pact. We must bring salvation back. Where there is love, I'll be there. I'll be there. I'll reach out my hand to you. I'll have faith in all you do. Just call my name. I'll be there. I'll be there. I'll be there to comfort you. Build my world of dreams around you. I'm so glad that I met you. I'll be there when love is flown. I'll be your strength. I'll keep holding on. Let me fill your heart with joy and laughter. Togetherness is all we're after. Whenever you need me, I'll be there. I'll be there. I'll be there to protect you with an unselfish love that respects you. Just call my name. I'll be there. I'll be there. I'll be there to comfort you. In my world of dreams around you, I'm so
Welcome back, everybody. I hope you enjoyed that beautiful music. We are so appreciative to our team, and it's amazing what we're able to do over technology these days to pull everybody together and all their beautiful voices. So we're going to tackle now a number of questions. We've had a lot of great questions that we see here coming in, and so I'm going to kind of call a few audibles and jump to some of the high interest questions, because we've tried to answer a lot of these through the course. So I'm going to start with Dirk, and a lot of questions around asymptomatic people. Do we really understand that? We're seeing differing data now around, are they transmitting the virus? Are they not transmitting the virus? Tell us a little bit about what we know.
Well, like a lot of things about this disease, there's a lot we don't know, and there's a lot of controversy. And it was really stoked by somebody from the World Health Organization recently saying, it doesn't happen, it's very rare. Nobody who's asymptomatic actually transmits this disease. Within about 24 hours, the WHO had walked that back and, said, well, we're not so sure. So here's the best understanding that I think we have at the moment. And like all these things, this is subject to change. Number one, how many people are asymptomatic, quote unquote? Studies vary, but it's anywhere from 20 to 80% in different studies. So either a significant minority or actually a majority of people who are infected with this virus are quote unquote asymptomatic. When you really dig down into what asymptomatic means, most of those people who are quote unquote asymptomatic are either minimally symptomatic, and if they find out they have a positive test. We had this over and over again with our employees when we were doing the surveillance. I have a positive test? I had the sniffles, a couple of days ago. I just thought it was my allergies, because I feel like this every year this time. So it's either that or people who are pre-symptomatic. They have a positive test, they feel fine, and then in 2 or 3 days they're, oh my goodness, I'm sick. So those people who are either minimally or pre-symptomatic clearly can transmit the virus. Those who are absolutely do not have a symptom at all, it's unclear. And one of the key groups that refers to is children, because children generally have a very high rate of being completely asymptomatic. However, it's been shown that in their tissues and their secretions and so forth, they have very, very high levels of virus, even if they're asymptomatic. So you better assume that an asymptomatic person can give you the disease. And generally, people are at the highest level of contagiousness a couple of days before they become symptomatic to about a week after. So there's about a 10-day period of the greatest risk.
Thank you, Dirk. And I'm going to ask a follow-on question. I will say that the CDC has decided to use 35% in their modeling assumptions as the asymptomatic percentage. Now, whether that's right or wrong,
Sure.
None of us know, but that's where they've chosen to do that. So there's also, early on, everybody was preaching, don't touch surfaces, wipe down all your groceries, all these different things. And now we've been hearing differing things that maybe there's not as much risk from, objects. Talk a little bit about what we're seeing there.
Yeah, well, COVID-19 research proclamations, the only thing that's more changeable is nutrition research and what's safe to eat or not eat, So if you feel kind of whipsawed by the constantly changing advice, I don't blame you. I kind of feel the same. But yes, that is the current thinking, is that, yeah, the virus does live on surfaces for some period of time. It's probably a shorter period of time than we feared. A lot of the quote-unquote detection of viruses on surfaces after hours or days is probably some viral RNA that's not a complete infectious viral particle, but just kind of a residual debris. That's not to say you should not practice hand hygiene. You should do all that stuff. Use sanitizer. Soap and water for this virus is actually better than sanitizer, or at least as good. Don't touch your face and all those kinds of things. That is, you can definitely get it from those things. But like with any, if you will, poison or infectious agent, the bigger the dose you get of this virus, the more likely you are to A, become sick, and B, become more severely ill. So if somebody sneezes in your face, that's a whole lot worse than, you touched a bag of groceries that was touched by an infected person, or, had been sneezed on several hours before. And that's where you get into the whole issue of masks. And I can tell you, I wear a mask all the time, except when I'm on TV. And I thoroughly recommend it. It is really, really good for protecting against droplets, which are probably the major mode of transmission. There's a lot of evidence now that maybe there is some degree of aerosolization and aerosol transmission, which is much more dangerous, much more persistent. And that's a great reason to wear a mask. So
perfect. Well, thank you. Roberta, so we got a couple questions about personal protective equipment. Just very briefly, can you tell us how we stand with all of that?
Sure. It's amazing actually to follow up on Dirk's last answer with the PPE question, which we often get asked, do we have enough? Do we have enough personal protective equipment to treat all of the patients that need to be treated at Houston Methodist Hospital and protect our frontline workers? And when we talk frontline, we talk about all of our 25,000 employees that are here, as well as those people who come in and out of the facility. I would tell you we're actually in much better shape now than we were 3 months ago. To a certain extent, when you really look at the PPE, we've moved to reusable PPE as opposed to disposable. At first, that was a pretty big change actually for our employees and everybody. The question of you have a throwaway mask rather than a mask that is launderable and comes in and out after going in the laundry. At first, that was a very nerve-wracking change, whether it was gowns or masks or other kinds of equipment. Now, actually, that we're in this spirit, I would tell you transmission between patients and healthcare workers is very minimal. Almost none. And it really is something that probably will sustain us into the future. I think about why didn't we do this earlier? Sometimes when you have to is when you do things. But I do feel like we've actually got what we need to for a very long time into the future.
Thanks. And quickly, we got a couple questions about our visitor status, because of course we had a no visitor status for quite some time. That is not the case now, but of course it's still quite limited. Can you just crisply talk about what our current visitor status is?
Sure. In the organization, one of the things we're trying to do is limit traffic, right? Waiting rooms weren't built to have socially distant. You'll see in every one of our waiting rooms, there's blue tape over them. Please don't sit here. In order to keep just the patients and the visitors socially distant, we are asking for just one visitor to come with individuals. I know that's very hard for families. We are also asking for that to be the same visitor. So if someone's here for an inpatient stay, we're asking them to designate one visitor. If that's a hardship and someone is just exhausted and needs to trade out, we are letting the local units actually make those decisions. But the reason for designating one person is that we don't have a new level of traffic coming through the organization who may not have really thought about and screened as well as other individuals that have really designated themselves. So again, it's one visitor, but it's one designated visitor who will stay with the person for their stay. And if people are comfortable having no one, that's actually a preference. A lot of our ICUs are asking people to leave at the end of visiting hours. So again, we limit the traffic walking around the halls and we limit those people through. Again, if someone is needed and essential, absolutely, they need to be with the patient.
Thanks, Roberta. Dirk, we got, I showed some data that maybe even our mortality rate's starting to come down. We're seeing less ICUs. We still don't fully understand that, and it may just be a delay. But there's some chatter out of Italy and a couple other places that perhaps the virus is less severe. Give us your thoughts on that.
Well, as it happens, my best friend is a critical care doctor in Florence. So, and this is what he tells me. He said, you know, we just don't have anybody in the ICU anymore. And he sounds like vaguely disappointed by this.
I'm not.
But this is a big topic over there. And there are a couple of virologists in Italy who claim that the virus is mutated and it's a weakened strain that is less dangerous. I would say this is kind of a fringe point of view. What we have seen here in Houston is that, you know, viruses mutate, that's what they do, and this one is no exception, but it's mutating rather slowly, and we're not seeing any big change in the genome of the virus that would correlate with a change in, you know, severity. So my guess is that what people are seeing in Italy, and as you pointed out, Mark, what we're seeing a teeny bit of here with the flatness of the ICU admission curve. It's a little bit of social distancing. People are getting smaller doses of the virus than they used to get. And again, like a poison or anything like that, the smaller dose, the better. Probably we're seeing some better protection of vulnerable groups like people in nursing homes. So I think it's more of those kinds of demographic behavioral things than a change in the virus.
Yeah. Okay. Well, I mean, there's good news in that statement, and maybe we can hope and pray there's something else too. But I'm with you. I think that's still pretty unlikely from what we've seen, certainly from some of the genomic studies that our team have done and other things to suggest that there's been some major change. I do think we've all gained a lot of experience in caring for it. So I got a lot of questions about what to do with children and what precautions to use. A couple have asked, and one came in now of, hey, what are you doing with your own family? And that may actually be a pretty good way to describe kind of my thoughts around this. And let me start by saying I'm not a pediatrician. My wife is. She's really smart, but I am not a pediatrician. My wife is out there seeing patients, swabbing patients, doing all the things that one does on the front lines. I don't do that, obviously, but I've been at work every day for months now, interacting with many, many people, far fewer than usual. We have a daughter who's a medical student. She was out of clinic for a while. She's back in clinics and seeing patients each and every day. During the height of this, we had her volunteering at the food bank. And so, with safe precautions out in the community, doing things to help the community. Our son's a college student, and right now the discussion is, we're going to do everything we can to get him back to college, but boy, it's going to be different and it's going to be abnormal. And then our youngest is going to be a freshman in high school. And she is a volleyballer. And, one of the big questions we asked ourselves is, do we let her go to that? And, we've done some private things and small group kinds of things, but decided, the big volleyball group, probably not for us. I've not eaten at a restaurant since before this started as a family, or me personally. We've done lots of takeout to support restaurants. Still not thrilled with restaurants. I'd never walk into a bar right now. I wouldn't walk into big crowded places like that where people aren't observing social distancing. And frankly, if I walk in someplace that looks like that, I walk back out. That's what I do. Go to the supermarket all the time. I'm masked up. Thankfully, at least the supermarkets I've gone to, most people are masked up. And, in terms of our daughter in school in the fall, we have every intention of her going to school in the fall and talking with school officials. And I've done a lot of that around town. I think they have really good plans in place. Now, the big if is going to be what the virus does over this summer. This is back to, we can't let this curve get out of control that is going up now. If it gets out of control, all bets are off, and probably schools are not the right thing and everything else. If we can figure out a level where the hospitals can care for people, where, this isn't rip-roaring through the community, I think schools will make sense at that point in time. And I wish I could give you better guidance now. Some of this is going to be a TBD as things evolve over the course of the summer. Knowing what I know now, if we could not keep going up, yes, I would be comfortable with schools opening with all the right precautions. And they're going to be very different places than they are today, as all places will be. I think that makes sense to me. So I've got time for like one or two more questions here.
Mark, do you want
go
to
ahead,
address
Roberta.
your parents?
And
because the questions are coming in about your elderly parents
Oh,
and what you're
okay.
doing, which I think is an important
Sure,
question.
I can do that, and with apologies to my parents who don't like being called elderly, and I know they're watching right now. So Mom, you can get Roberta later.
Good job, Roberta.
My parents, Julie's parents, have mostly stayed home. Obviously, I've had them to our house. For Mother's Day, we did a big socially distanced, everybody sitting at tables in the backyard outdoors. My father-in-law had his 80th birthday last weekend, and we did a drive-by session, with like 40 different cars came by, but done very fun. It was actually a ton of fun. It was really unique. It will be a memorable 80th birthday. We bring them food. We try to not have them go into the grocery stores very much. They've done a little bit socially with friends in a very distanced manner. All of that's appropriate. Would I tell my parents or my in-laws to go to the club, go to a restaurant, et cetera? No. I mean, frankly, especially now as we're seeing the virus come back up, I don't think now's the time. I haven't kissed my mom or hugged my mom in a few months. I hate that. But I stop by all the time, and I want to keep them safe. They are in a high-risk group. I will say across Houston Methodist, where we've had tremendously good experience, 80 and up, it's 30+% mortality. Now the caveat, remember, there's some of those folks come from nursing homes and may have do not resuscitate orders and other things, but nonetheless, this is really challenging just with age, even without a lot of underlying conditions. So that to your question, Roberta, and you'll see my mom because she volunteers here. I'm sure she'll get back at you someday, but we don't let her volunteer right now because no volunteers above 60 right now, even doing the hospital. Though we're doing some virtual digital types of volunteering. My father does a pet visitation digitally, which is really cool. So
Well, I can chime in. So I'm 72. And I have no health issues, and that correlates with about a 10 to 12% mortality rate. So, if I go out for a run in the park, I wear a mask. A lot of people don't, but I do. I can't live without going to the gym. So when the gym in my building reopened, I started going to the gym. But you should see me. I wear gloves, I wear a mask, I wear a baseball cap, I wear long sleeve t-shirt, As soon as I get finished, I strip off the gloves, I sanitize my hands, I take a shower. I think the message that we would all sign on to is that we showed that we can control this thing. And the issue is, how much can we get back to normal while still controlling it? And I think that if everybody behaves sensibly, which a lot of people aren't now, we can go back to pretty normal lives while keeping this under decent control. I don't know.
Yeah, and I would say if you look at our COVID units that are so good at donning and doffing equipment, at masking, at gloving, at hand sanitizing. If you look in the hall, I think we go through, we're now at about double the rate of hand sanitizer than we were pre-COVID. Even though we were good before, now we're really good. The transmission to healthcare workers is almost none. So it shows you that when you're in the wake of treating 4 to 5 COVID patients a day, all day long, you can walk away not picking this up if you do the right thing.
So that's a really great debate, and to kind of bring things towards a close. And Dirk, big amen to all of that. Is our goal needs to be to do all of this, and I firmly believe we can. But it's every one of us working together. I call it a social contract, and it's me looking people in the eye and saying, "I got your back, you get my back." And if we all do these things together, it won't be normal, it won't be perfect, but we can get relatively close to normal, get through this period, have an economy that runs, have schools open, be able to do things we want to do, and move things forward. But if we take down our guard and let this get out of control, it may be a different story. So I want to end with a video we're going to show you, which is a thank you video to our staff that many of you helped us with as well. We've, as we talked about before, have a program in place to thank over 6,000 of our staff with either 8 or 12 hours of time off based on their shifts. $100 gift that they can use to spend time with their family and do something that's meaningful to them with their family. We've done some other programs for about 2,000 employees ourselves that were really at the sharp end of things, and really people taking care of patients with COVID. And this runs the gamut from our wonderful housekeeping staff who are out there keeping our place clean and walking in and cleaning the rooms of patients with COVID and interacting with those individuals, to food service personnel, to transporters, to people working in the lab who've gotten all the testing done, and of course to the nurses and others on the front lines, and many others. I can't name all of them. And so it's a beautiful program. We appreciate everybody's great support of that. Let me show you that video now. Thanks. Dear frontline heroes, you are doing amazing things during these unprecedented times of COVID-19. You have astonished us with your brilliance, innovation, and compassion. You inspire us all.
You continue to uphold our eye care values as we unite to fight this pandemic.
Your bravery, dedication, and commitment to bringing innovative treatments and therapies to our patients inspires hope, not just for COVID-19 patients, but for all.
You continue to lead medicine while upholding unparalleled safety, quality, service, and innovation.
And you continue to put your life on the line every day to help our neighbors.
Words cannot express how brave, selfless, and heroic every one of you are.
You are making a difference in our patients' lives and the Houston community.
We are forever indebted to you.
We are so grateful to you for taking such good care of our families and loved ones while you sacrifice time away from yours.
Thank you for waking up every day, choosing to keep up the fight.
Thank you for never giving up on yourself or your team.
Thank you for holding our patients' hands when their families can't.
Thank you for your courage,
For your strength,
For your resilience.
thank you for giving us hope,
For your compassion.
and for your innovative research,
Thank you for giving us the gift of your time.
and for remaining committed to serving all patients throughout this pandemic.
We know the sacrifices we are asked to make.
Pale in comparison to the sacrifices you make every day on our behalf.
For all you've done and all you will do, we say thank you today.
Thank you.
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 Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
We are proud of our Houston Methodist COVID-19 heroes.
The work you are doing is divinely guided.
We are keeping you and your families in our prayers.
We are with you, praying for you daily. May the Lord be with you.
From the bottom of our hearts, thank you. We are with you every single step of the way. Houston Methodist, we can and we will prevail. So on that note, I want to say thank you to each and every one of you. Thank you for the palpable support each of us have felt during this marathon, and our staff have felt, our physicians have felt. Thank you for helping us carry the message out to the community and educating the public and working together to do the right things. Thank you for your never-ending support of Houston Methodist and the mission we have to be the best hospital system anywhere on the planet and to care for the citizens of Houston in unparalleled fashion. We deeply appreciate each of you. We wish you blessings and look forward to talking to you again. And I hope we're looking at some better numbers the next time. God bless.